Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're tackling unstable angina and non-ST elevation MI, or NSTEMI, two closely related acute coronary syndromes that as PAs we must recognize quickly. These conditions can be life-threatening if not managed properly, and early intervention is key. We'll break down what makes these conditions unique, how to diagnose them, and the latest management strategies so you're prepared whether you're studying for the PANCE or a practicing PA. Let's dive in. So what's actually happening in unstable angina and NSTEMI? Both are caused by plaque rupture and thrombosis in the coronary arteries, leading to partial occlusion of the coronary artery and decreased blood flow to the heart. However, the difference lies in myocardial injury. Unstable angina involves ischemia without actual infarction, meaning there's no significant cardiac muscle damage or myocardial cell death. Troponins are not elevated. However, there may be ECG changes indicative of the ischemia. NSTEMI, on the other hand, involves some myocardial injury, but it's not full thickness like an ST elevation MI or STEMI, which will be covered in another episode. Since elevation in troponins may not be detectable for hours after presentation, unstable angina and NSTEMI are frequently indistinguishable at initial evaluation. As a consequence, initial management is the same for these two syndromes. For this reason, and because the pathogenic mechanisms of the two conditions are similar, they are often considered together. Now, who do unstable angina and NSTEMI affect? They primarily affect individuals with coronary artery disease. Risk factors include hypertension, hyperlipidemia, diabetes, smoking, older age, especially over 65. Men are at higher risk than women. History of prior coronary artery disease, myocardial infarction, or revascularization. Cocaine use, which can cause coronary vasospasm and mimic acute coronary syndrome. Ethnicity is also a factor, and Blacks, Hispanics, and Southeast Asians are at increased risk. A positive family history of coronary artery disease, and obesity, poor diet, and sedentary lifestyle. It's crucial to recognize high-risk patients early because time is myocardium. Now, how about the clinical presentation? Patients typically present with chest pain or discomfort, but the way it manifests is key. Patients may have angina equivalents such as discomfort to shoulders, arms, neck, back, upper abdomen or the jaw, diaphoresis, shortness of breath, nausea or vomiting, fatigue, especially in elderly and diabetic patients who may have atypical presentations, and some other symptoms are dizziness, indigestion, syncope, and palpitations. Now, going back to the atypical presentation, this is usually more common in women, elderly, or patients with diabetes. And what's meant as atypical presentation could be dyspnea alone, weakness, nausea and/or vomiting, epigastric pain or discomfort, palpitations, syncope, or cardiac arrest. When comparing to stable angina, which is typically exertional chest pain, unstable angina occurs at rest or with previously tolerated levels of exertion, has no predictable pattern, and is not relieved with rest or nitroglycerin. The initial physical exam should focus on findings that permit rapid triage and aid in immediate diagnosis and management. So you want to think of your ABCs. So check patient responsiveness, airway, breathing, and circulation, evidence of systemic hypoperfusion, so assess for hypotension, tachycardia, impaired cognition, or cool, clammy, pale, ashen skin. You also want to check for evidence of heart failure. So check for jugular venous distension, new or worsening pulmonary crackles, hypotension, tachycardia, a new S3 gallop, or a new or worsening mitral regurgitation murmur. Now, an important note is that bradycardia can be a sign of right coronary artery occlusion. because if you think back at your anatomy, the right coronary artery supplies the SA and AV nodes. Now let's move on to the diagnosis. The key to diagnosing unstable angina versus an NSTEMI lies in the history, physical, electrocardiogram, and cardiac biomarkers. Let's talk about the electrocardiogram first. If a patient presents in the ER with chest pain, the electrocardiogram should be obtained within 10 minutes of arrival. It is important to know that a normal initial ECG does not rule out an acute coronary syndrome. If there is suspicion, serial ECGs should be obtained. In unstable angina, the ECG may be normal or show transient evidence of subendocardial ischemia with ST segment depression, T-wave flattening, or T-wave inversion. In an NSTEMI, the ECG may also be normal or may have ST depression or T-wave inversion in two contiguous leads. If ST elevation is present, you want to think STEMI instead. Also, keep in mind that a new left bundle branch block with associated symptoms is a STEMI until proven otherwise. Next, let's talk about the cardiac biomarkers. Troponins are the game changer. They are structural proteins in the heart that are released as a result of myocardial injury. An NSTEMI will have elevated troponins, indicating myocardial injury. Unstable angina will have normal troponins. CKMB is another cardiac biomarker, but it is less sensitive and specific than troponin. However, it is very useful when suspecting reinfarction, due to the fact that CKMB normalizes within 48 to 72 hours after an MI, versus troponin, which returns to baseline over 4 to 10 days. If a patient is suspected of a reinfarction, say 3 or 4 days after an MI, a CKMB will show an increase confirming your suspicion. One more little note here is to keep in mind that there are other causes of increase in troponin, not just in myocardial infarction, such as arrhythmias, cocaine, coronary embolism, percutaneous coronary intervention, aortic dissection, electrical shock, hypoxia, myocarditis, chronic kidney disease, and stress cardiomyopathy. Now, you'll also want to order additional labs to assess associated risks or triggering factors and prognosis. This would be a CBC, a complete metabolic panel, lipids, A1C, a B natriuretic peptide, coagulation studies, and toxicology testing if needed, and additional imaging as indicated, such as a chest X-ray, to rule out other causes such as aortic dissection or pneumothorax. The management revolves around early stabilization and preventing progression of infarction. You want to initiate medical treatment within 20 minutes. A mnemonic to help you remember this treatment is MONA-B, M-O-N-A-B. These letters stand for M for morphine, O for oxygen, N for nitroglycerin, A for aspirin, and B for beta blocker. Let's talk about each one of these. Morphine is given only if pain persists after nitroglycerin. Oxygen is given if the oxygen saturation is less than 94%. Sublingual nitroglycerin is given to patients presenting with ischemic chest pain, followed by intravenous nitroglycerin in patients with persistent pain after 3 sublingual nitroglycerin tablets, hypertension, or heart failure. Nitrates must be used with caution or avoided in settings in which hypotension is likely or could result in serious hemodynamic decompensation, such as right ventricular infarction or severe aortic stenosis. In addition, nitrates are contraindicated in patients who have taken a phosphodiesterase inhibitor for erectile dysfunction within the previous 24 hours. Next is the A for aspirin, which 325 milligrams of chewed aspirin is given. And beta blockers are given to reduce myocardial oxygen demand and should be given within 24 hours in patients without any contraindications. Now, although not part of the mnemonic MONA-B, A high-intensity statin should also be given as early as possible. Now, the patient will require risk stratification to determine further cardiac testing and management. There are several scoring systems, such as the TIMI score and GRACE, but one that's commonly used is the heart score. H for history, E for ECG, A for age, R for risk factors, and T for troponin. This will give a score of low, intermediate, or high risk that will then guide the management strategy of a conservative ischemia-guided strategy which avoids invasive procedures unless there's hemodynamic instability or recurrent refractory ischemia, or an invasive approach which includes percutaneous coronary intervention or a CABG, which is a coronary artery bypass graft surgery. The decision on an invasive versus non-invasive approach will guide the choice of antithrombotic and anticoagulation therapy, which are also important components of the management. Now, regarding prevention, preventing further events is key in long-term management. This includes lifestyle modifications, such as smoking cessation, diet, and exercise, aggressive risk factor control, which includes blood pressure, cholesterol, and diabetes management, and adherence to medication regimen after the acute coronary syndrome, which includes a high-intensity statin, beta blocker, an ACE inhibitor or an ARB, and aspirin for both unstable angina and an NSTEMI. In addition, NSTEMI patients should also be on a P2Y12 receptor blocker for dual antiplatelet therapy. Now, let's talk book med versus street med. Textbooks make it sound easy. Any patient with chest pain gets the full acute coronary syndrome workup and treatment. But in real life, we see lots of gray areas, especially when patients present with vague symptoms or have confounding factors like anxiety or GI pain. Clinicians play a big role in risk stratifying patients. Knowing when to escalate care and when to reassure is key. Now, before getting to our questions, here are some clinical pearls. Number 1. Unstable angina and NSTEMI are differentiated by troponin levels. NSTEMI has elevated troponins because remember, this involves myocardial cell death. Number 2. Always rule out STEMI first. ST elevations require emergent reperfusion. And number 3. Fibrinolysis is not beneficial and therefore not indicated in an NSTEMI or unstable angina. Alright, let's practice some questions. Question 1. A 58-year-old woman presents with substernal chest pain that started while she was watching television. The pain has been present for 30 minutes. Patient has history of diabetes mellitus type 2 and hypertension. Electrocardiogram shows ST segment depression and T-wave inversions in leads 2, 3, and AVF. Troponins are normal. Which of the following is the most likely diagnosis? Is it A, NSTEMI, B, unstable angina, C, STEMI, or D, vasospastic angina? I'll give you a couple of seconds. If you chose B, unstable angina, you are correct. The chest pain with electrocardiogram changes, but normal troponins suggests unstable angina rather than NSTEMI, which would have elevated troponins. Question 2. A 60-year-old man presents to the emergency department with chest pain that started 30 minutes ago while he was at rest. He describes it as a pressure-like discomfort in the center of his chest, radiating to his left arm. He has a history of hypertension and hyperlipidemia, but no prior cardiac events. On arrival, his vital signs are stable. ECG shows ST segment depression and T-wave inversions in leads V5 and V6, and initial troponin is elevated. Which of the following is the most likely diagnosis? Is it A, stable angina, B, vasospastic angina, C, NSTEMI, or D, STEMI? If you chose NSTEMI, you are correct. This patient has ischemic chest pain at rest, electrocardiogram changes, and elevated troponins, which confirm the diagnosis of an NSTEMI. Stable angina would present with exertional chest pain that resolves with rest and normal troponins. Vasospastic angina is often seen in younger patients or those with a history of smoking or drug use and presents with transient ST segment elevations or depression. And a STEMI would show persistent ST segment elevation. Great job! That wraps up today's discussion on unstable angina and NSTEMI. These conditions require quick recognition and proper risk stratification to prevent progression. Keep these pearls in mind when assessing chest pain in your patients. If you enjoyed this episode, make sure to subscribe. And remember, this is the ProPA podcast, where future pros in medicine are made. See you next time.